So our next talk is Remembering Pilocarpine and the Relevance of PGA in PACG by Dr. Chandrima Paul. Dr. Chandrima is the Director and Consultant of the Glaucoma Service at BBI Foundation Group of Hospitals, West Bengal. She has done her graduation and post-graduation from Silchar Medical College, Assam. She has also trained under the renowned surgeon Dr. Howard Fine at Oregon Eye Center, USA. She has completed her PhD in ophthalmology with a subspecialty as glaucoma from RIO Kolkata. She has received the prestigious D.B. Chandra Award at AIOS and B.K. Mitra Award in the West Bengal Ophthalmic Society. Welcome, ma'am.
Thank you very much, Dr. Shoruba. I'll share my screen. Thank you, Dr. Shushma, for giving me this opportunity this evening. And it's always a privilege to have Dr. GC on the chair, because every time that I've heard him, I've always learned something from him. So remembering pilocarpine and relevance of PG analogues. So in medical school, we heard that if angle assessment is not possible, remember pilocarpine. The first part of the statement, I would say, doesn't hold true anymore, because we must do a gonioscopy, actually, come what may. But the second part of the sentence, let's remember pilocarpine, yes, we should remember pilocarpine. So, well, pilocarpine, the origin of the drug, was obtained from the leaves of Pilocarpus microphyllus. It's a South American shrub and was isolated as early as 1875. That's the molecular structure. And it's a myotic. So myotics are parasympathomimetic drugs that act by stimulating muscarinic receptors in sphincter pupillae and ciliary body. In primary open-angle glaucoma, intraocular pressure by contraction of ciliary, it reduces the intraocular pressure by contraction of the ciliary muscle and increases the aqueous outflow through the trabecular meshwork. In angle closure glaucoma, it reduces the intraocular pressure by contraction of the sphincter pupillae, causing meiosis, and pulls peripheral iris away from the trabeculum, opening the angle. That's a more of a mechanical action. So just to emphasize the importance of gonioscopy, that's an open angle that we see out there. We can clearly see all the structures that one is supposed to see while doing a gonioscopy. And this is a closed angle where we cannot see a single structure. So that's on UBM, an open angle. And that's a closed angle. What is important to remember here is the scleral spur. That is the identification point on the UBM. And that's the anterior OCT. We have a lot of talks on anterior OCT, but as far as angle closure is concerned, the UBM gives you much more depth than the anterior OCT. So before laser peripheral iridotomy, the code from Krupin et al. Was pilocarpine 2% or 4% was administered in all patients prior to laser surgery to have a myotic pupil and the iris under tension. Well, that holds good even today. We do use pilocarpine. We do not get the 4%, but we use the 2% to cause meiosis and reduce iris thickness and facilitate perforation. So the biological mechanism of pilocarpine to induce meiosis quantifies short-term constriction of the pupil induced by pilocarpine, and it's very significant. So meiosis begins in about 15 to 30 minutes and lasts for about 8 hours. Pilocarpine also causes meiosis by direct action on the receptors of the pupillary sphincter, and this meiosis may last even up to 24 hours and cause spasm of accommodation. So because of its activity at the muscarinic receptor sites on the iris sphincter and ciliary muscles, pilocarpine causes pupillary constriction and varying degrees of accommodative spasm depending on the patient's age. And in all comparative studies comparing the effect of pilocarpine to other drugs or combination, meiosis is mentioned as the reason making mask studies very impossible. And this I really found whole goods, because searching the literature, I could hardly find any recent studies, because it's almost impossible to do a study with pilocarpine where you have to cause meiosis. So that's the UBM picture. This is a UBM picture of the closed angle. That's pre-pilocarpine, and that's post-pilocarpine. And this is post-YAG-PI. So coming to Plateau iris, which is very significant in this talk. So the prevalence is about 32.3% in a cohort of primary angle closure suspects using UBM. Risk factors are female, younger age, 30 to 50. Often family history is positive, less hyperopic than patients with primary angle closure. So the Pathophysiology is anteriorly positioned ciliary processes. A component of pupillary block may be present. And here we need to distinguish between the plateau iris configuration and syndrome. So the plateau iris configuration is flat central iris plane, but normal AC depth. Angle recess is very narrow with a sharp iris angulation over anteriorly positioned or oriented ciliary processes. A component of pupillary block is present and a peripheral iridotomy is curative. In plateau iris syndrome, occurrence of angle closure despite a patent iridotomy in a patient with morphological plateau iris. So in the presence of an anteriorly directed ciliary body and absent ciliary sulcus, a steep iris root from its point of insertion, followed by a downward angulation from the sclerocorneal wall, the presence of a centrally flat iris plane and irido-angle contact. So if you look at that picture out there, plateau iris, a large and anteriorly positioned ciliary body, holds the iris root up against the cornea, leading to a partially occluded angle. The arrows represent the location of the sclerospur. That's the sclerospur, and there I'll just come into the double hump. So the indentation UVM on an eye with plateau iris, the double hump sign, you can see that's actually in gonioscopy where you see the double hump sign or the sine wave sign as we call it. And that's in the UVM where also you see one hump owing to the ciliary processes and the other hump owing to the lens. So pilocarpine 1% muscarinic agents, these facilitate aqueous humor outflow through the ciliary muscle contraction, distance the iris peripherally from the trabecular meshwork and prevent synechia formation, but do not totally remove iridotrabecular contact. Miotic agents open the angle, reducing the intraocular pressure by 20 to 25%. Adverse reactions can be local, ocular pain, conjunctival hyperemia, pupillary constriction, myopia, or even retinal detachment, or in general bronchospasm, headache, and intestinal cramps. This treatment is an option for acute and intermittent angle closure and is mainly reserved for patients who do not consent to laser therapy. Miotics can also be used for the prevention of the angle closure after laser iridotomy or argon laser peripheral iridoplasty. So next we move on to the game changer. The game changer today is none other than the PG analogues. My previous speakers have very beautifully spoken about PG analogues, so I won't go into the details. I'll just cover up a few points. That is, just looking at the glaucoma treatment landscape. Latanoprost came in as early as 1997, which was followed by bimatoprost, then travoprost, and finally trafluprost. And prostaglandin analogues in the eye, I wouldn't go into the details of how they function because my previous speakers have already said all that. So I'll just move on to a few points like we use tafluprost, latanoprost, travoprost, and of course bimatoprost. The difference between them, as we all know, are these are one is the bimatoprost is a amide and the other are esters. So prostaglandin analogues, it is the drug of choice in primary open angle glaucoma and normotensive glaucoma, PI in angle closure glaucoma, and really have no side effects except, of course, you can't use it in pregnant women. And compliance improves because it's a single application. So in this talk here, actually, the relevance is post-IAC PI. You can actually use a prostaglandin analog. And interswitching among them, studies have shown that patients not responding or intolerant to one class of PGS benefit from switching to another class of PGS. Contraindications, I wouldn't go through it because it was dealt with very nicely by my previous speakers, so I won't go into that. So just the comparison that PG analogs are the most effective when compared to the carbonic anhydrase inhibitors or the alpha agonists or timolol. And the 24-hour effect of medications, well, if you look at that, then latanoprost actually, as opposed to prostaglandin analog, has the best IOP lowering activity, both when you compare it to the other drugs and even on a baseline IOP, it has the best effect of IOP lowering efficacy. And if you look at this, that is over a 24-hour period, then compared to a beta blocker, a prostaglandin analog has much better effect, especially at night in lowering IOP than the contender beta blocker. So for controlling intraocular pressure, recent studies have suggested evidently that latanoprost, travoprost, and bimatoprost provide a significant IOP lowering efficacy in eyes with angle closure glaucoma and are as effective as timolol for the same. So statistically speaking, the efficiency of these three drugs is similar when compared to each other. And recent studies, as we just spoke about it, about the bark-free and the preservative-free, we just spoke about them. So PGAs are also very effective when they're added to either alpha agonist or a beta blocker or a carbonic anhydrase inhibitor. And they can be successfully combined with any of them. So issues to consider when starting a prostaglandin analog: we need to take a history of any active inflammation or a history of cystoid macular edema. And if the dosage in one, if you're putting it in one eye, it has to tolerate the potential asymmetric changes that happen. And that's actually an article which we published just to show that angle closure is almost as common in primary glaucoma. And that's the reason. So what we see depends on what we look for. Thank you very much.